Here we're seeing a chest x-ray showing about a 20% pneumothorax on the left side. This is a close-up view that now demonstrates the pleural line as is shown there. Here we're identifying the spot along the anterior chest wall in the midclavicular line just above the third rib, where we're going to perform the insertion of the pigtail catheter. We're identifying that with the tip of a ballpoint pen. During the timeout procedure, we put our initials. Here we're prepping with chlorhexidine swab the anterior chest wall, and we're drawing up 1% lidocaine into a sterile syringe and needle for local anesthesia. Here we're prepping with sterile blue towels the left anterior chest wall. We're using 1% lidocaine for local anesthesia of the skin, and we are gradually inserting and then aspirating to make sure we're not in the pleural space before local anesthesia of the subcutaneous tissue. As we insert the needle, we are constantly pulling aspiration to make sure we are not in the pleural space. Once we get a steady stream of bubbles, we know we're in the pleural space, and that is the appropriate depth of insertion of the pigtail catheter. When we advance the needle about 1/2 centimeter without getting bubbles, then we're administering more local anesthesia. Now we see a steady stream of bubbles, therefore we know we are in the pleural space. We then withdraw the needle until we're no longer seeing a steady stream of bubbles. So we're right outside of the pleura. We can then administer a large amount of 1% lidocaine to now numb up the pleura. The needle is now being advanced back so we know the depth of insertion into the pleura. And there we have the steady stream of bubbles. We're going to grasp the needle, and that is our depth of insertion into the pleural space. Now we're going to activate the pigtail catheter. The first thing we do is pull off the black protection, and then we will advance the gray dilator to gradually lengthen the catheter. We're going to use our finger along the side of the catheter to straighten it out as we push the needle through the catheter. So now it's a fully straightened catheter. We will now use a little bit of the 1% lidocaine to moisten the catheter, which allows it to pass through the subcutaneous tissue easier without any friction. We're using the needle with the appropriate depth of insertion to determine which of the holes along the side of the catheter corresponds to the depth of insertion, and then we will go 1 centimeter beyond that to determine our depth of insertion of the pigtail catheter. We're going to use a scalpel to make a skin nick, and then with our thumb on the needle, we will advance the pigtail catheter perpendicular to the skin over the third rib in the midclavicular line until our fingers of our left hand are touching the skin, which will indicate the appropriate depth of insertion into the pleural space. We can use a little bit of 1% lidocaine to moisten the catheter a little bit more if you're meeting resistance with the blunt dissection through the subcutaneous tissue. Again, the right thumb is driving the needle and the overlying catheter in through the subcutaneous tissue until you get to the appropriate depth of insertion. Now we're withdrawing the needle, so the only thing left is the gray dilator and the pigtail catheter. These will then be inserted together an additional 2 to 3 centimeters. Now we're going to hold the gray dilator steady as we advance the white pigtail catheter over the dilator until the large opening is at the skin. Again, more lidocaine is used to help the catheter pass more easily in through the subcutaneous tissue and into the pleural space. Once the large hole of the pigtail catheter is at the skin, the gray dilator can now be removed, as is shown there, and then the pigtail catheter is advanced to the last black line. We're now using a straight needle with 2/0 silk suture to make a air knot on the skin. With silk suture, you should put at least 4 throws of the suture to tie a knot. Scissors are used to cut off the needle. And now the suture is wrapped sequentially around the catheter so that we can tie a firm suture knot on the catheter. It's important to have a firm knot on the catheter, but that the knot is not too tight as to kink the pigtail catheter. Now we're going to cut a line through a sterile occlusive dressing, and then that hole is used to go around the catheter, so we have a nice sterile dressing around the catheter to minimize the chance of an infection. We're going to attach a special tubing to the catheter, which can then be attached to the chest tube drainage compartment with this 5-in-1 connector as is shown here. And then one clue that you're in the pleural space is that in the water seal compartment, you'll see fluctuations of the liquid up and down with respirations even before your post-procedure chest x-ray, which is shown here, that shows the pigtail catheter is in good position and the lung has re-expanded, so you have almost no pneumothorax present even immediately after the pigtail catheter is placed. As you can see there, the lung is almost completely re-expanded with only a minimal apical pneumothorax.